This session is about sports injuries and prevention. And as you know, this is the core of sports medicine. If you're a team physician, you're facing two questions. The coach, he will love you if he has the full team at his disposal, if he can field the whole team. If he cannot, he will question the doctor, why didn't you do the injury prevention? And obviously, once a player is injured, he will want to know what brings him back to the game as fast as possible. And this is a little bit the topic that this little session is going to highlight. And I have the honor of introducing our first speaker, Roald Bahr, who basically needs no introduction. He's a member of the IOC Medical Commission. He is a really good volleyball player, as you can see by his height. And he's heading the Aspetar Injury and Illness Prevention Program called Aspetar. So Roald, please, the stage is yours.
Thank you very much. I am delighted to be here today. And really appreciate the opportunity to share some thoughts with you about our approach to risk management in sport. And you may wonder, what's risk management? Because usually the term that's being used is injury prevention. I have no disclosures. And the model that's usually used for injury prevention research is the four-step model that Willem van Mechelen published in 1992. And the four steps go as follows. So first, you need to determine the magnitude and severity of the problems. So how many injuries are there? What types of injuries? How serious are they? Then the next step is to try to establish Is this working? Yeah, better. The next step is to try and establish the etiology. So this is the risk factors and the injury mechanisms. Because only when you know why and how injuries happen can you formulate a plan on how to prevent them. And then as a researcher, you would go back to step one again and test this and assess whether the plan that you developed is effective. So in short, the four-step model is very simple. First, what is the magnitude? Second, what are the causes? Third, do you then have some idea of how you can prevent injuries? And then you test this, preferably then in a randomized controlled trial. Now, this model is used by all researchers around the world who work in injury prevention. But it doesn't really fit with clinical practice, with your job as a team doctor, or as a sports scientist, or as a physical therapist working with a team, does it? So the question then is, can we translate this into something that is practical and usable in daily clinical practice? And the answer to that is risk management. Now, a good friend and colleague of mine, Colin Fuller, wrote a paper in 2007 where he outlined his risk management model. But I'm not that smart, so I really have problems understanding this model. It looks pretty complicated, doesn't it? So I've created my own, much simpler model, and this looks like this. It has four steps. The first step is risk identification. The second step is season analysis. The third step is athlete risk factor analysis. And then the fourth stage is assessing risk, accepting risk, or doing something to reduce risk. And I will use this as the outline of my talk. So the first step then, risk identification, involves getting an idea of what is the problem in your sport, and preferably in your team. You can do this based on the literature. There's probably 1,000 papers out there now on the epidemiology of football injuries, for instance. And you would be amazed to see how many papers there are on volleyball injuries or badminton injuries or any, you name the sport, someone has studied it, the data is there on how many injuries there are and what the injuries are. Now, how would you assess that type of information? And this figure here I've created to help you conceptually to address the issue of what are my priorities. If I'm going to address this from a prevention perspective, what should my priorities be? And if you look at this figure here, this pointer probably only works on one screen. So down here you have the rare injuries or the rare things. And over here you have the common things, the things that are almost certain to happen. And then this died too, all right? Not doing very well here. 1, 2, okay, now this works. It's good to have 2. Yeah. So this is the likelihood of something happening. And on this scale here, you have the severity of that incident. And to use some examples here, I've added cuts and bruises in particular. Now, if this is football, you are certain to have a player who has some bruises or scrapes after the end of the game. This is almost certain to happen, but it is insignificant. It doesn't affect his performance much, right? But we just heard about sudden cardiac death. It's up here. It is rare, but it is a catastrophic incident. And then we can add the typical injuries from football. Ankle sprains are likely to happen on your team, but they are minor. They'll keep the athlete out for a week or 2, usually, no more than that. Hamstring injuries now are even more common than ankle injuries, so they belong over here. They're almost certain to happen on your team, and they are more severe. They'll keep the athlete out in general for longer than an ankle sprain will. We can add ACL injuries here. If we're talking about male football, they're quite rare in European football, but if you're in the Gulf region, then they should probably be moved over here where they're more frequent. So what I've done now is show you a risk diagram, and now I've added some color. So where should your priorities be? Well, it's pretty simple. The darker the color, that's the area you want to address. If we had something that was catastrophic and almost certain it would be up in this corner, unfortunately we don't. But if I were working with a football team in the professional league, my focus would be on hamstring strain and maybe ankle and knee injuries as well. I would certainly include some sort of a program to ensure that none of my players die on the pitch. Now, if you're working with female athletes, this changes things. Or a different sport, that also changes this. So I'm using female athletes here to indicate how it might change, because we do know that ACL injuries are much more common among females. And we also know that hamstring strains are somewhat less common among female players than male players. So if you're working with a female team, maybe your list of priorities would look something like this. All right, this is the model. But you want your own data. And how do you get your own data? Well, you get your own data through injury surveillance, looking at the history of how the injury profile of your team has been during the past season, during years before. Data from the league that your team participates in is more helpful because it gives you a sharper tool. You are more likely to hit the nail. Now, remember the next step in this model is identifying risk factors or causes of injury. So what is the strongest risk factor for injury? So some suggestions coming up here: history of previous injury, or could it be the coach? I'm a Man U fan and I hate this guy, so I'm putting this up here on purpose. And this is where the next step in the model addresses this through season analysis. And what season analysis means is a formal review of the competition and training plan for the team. Before you start the season, you sit down, preferably with the coaching staff, and I would say also with some player representatives. Look at the plan and then review last year's experience in terms of where are the risky periods of the season. And this is just one quick example, and this would apply to a Northern European team, for instance, one from Norway, my home country, where every spring in January, February, or in the winter when it's cold in Norway, they go to Portugal or Spain for a 1-week training camp. The coach goes crazy. Now they're going to train twice a week, twice a day, so a morning session and afternoon session. They're suddenly on fresh grass. They're all like young bucks. And what happens? Well, the team comes back after a fantastic training camp, but half the team are injured. So this is obviously a very high-risk moment during the season. In this way, you can imagine you can address all the various issues, all the expectations in terms of what the risks are. This is season analysis. Best done if you have data on your team from past seasons. Oops. Then the third step, and this is what Steve talked about in his previous talk. This is knowing the profile of each athlete on your team. Knowing their risk factors, knowing their injury status. And as he also pointed out, this is best done at the end of the season, immediately after the end of the season, because then you still have time to fix the problems before the next season starts. Now, you might argue that I'm with my team, so I already know their problems, and that might be true, and that is probably the best way of addressing this, is to really have your finger on the status of each player, their injury status, and their risk profile 365 days a year. And nothing is happening here. Oh, there we go. So this is done here through the periodic health examination. And as Dr. Target just pointed out, the two main issues with the periodic health examination or the pre-participation examination is trying to determine the risk of future injury or disease. And that's another talk, this is very difficult. But at least determine the current health status of the player. So where are they now and what do we need to do to make sure that this player is 100% fit before the start of the next season. Here at Aspetar, we have the Aspetar Injury and Illness Prevention Program, and the screening exam done as part of the periodic health examination, as you've heard, is a very important component of our risk management program. Another factor that is very important is how you deal with return to play. So having a clear policy on return to play and making those decisions is obviously key in risk management with the team. The final step in the model is actually pretty simple. Either you accept risk, and in football, that is done by, if you can afford to have the best players in the world, 2 of them on each position, then you're fine. So if one is injured, the other player can step in and the team is as good as it was. If you don't have that much money, then perhaps you need to consider the other way of addressing this, and that is through injury prevention programs or risk mitigation, if you like. And I'm going to, so here at Aspetar, and here in Qatar, we're addressing these 4 steps, or attempting to address these 4 steps through our injury surveillance data that's collected by all teams in the QSL and some of the federations also now. Providing a benchmark for the team and for the league. And the second step, season analysis, can be done by reviewing past year's data, also based on this injury surveillance, which is key to this. The third step is based on both the risk profile from the periodic health examination and a review of the surveillance data for that athlete during the past season. And then the final step is obviously developing a formal risk management program for the team, which is what we're working on now with clubs and federations here in Qatar. I'm going to finish this talk then, because if you want to learn more about injury prevention, it gives me great pleasure in how you can prevent injuries to invite you to Monaco next year in March, 16th through 18th of March, where we will have what I think is going to be a phenomenal conference focusing specifically on injury and illness prevention. If you want to learn more about what's going on at the conference, you see the website here, and you also see the Twitter handles and the hashtag that's being used to provide information on the conference. And with this, I thank you very much for your attention.